Hi, I'm Dr. Lisa Hudgins, an Associate Professor of Pediatrics in Medicine at Cornell Medical College and the Rogosin Institute, and I've been the Director of Pediatric Lipids at the Comprehensive Lipid Control Center at the Rogosin Institute for close to 30 years, and have been involved in lipid research and treatment of homozygous FH for a long time. And I like to get on with your questions. HoFH is a genetic lipid disorder that leads to the highest LDL cholesterol level and a very high rate of heart disease, as well as aortic valve disease, occurring as early as young childhood and certainly untreated by the teen years. It's called homozygous FH because there is an abnormal change, at least one, that is inherited from each parent, and therefore there's a double dose that leads to these very high LDL cholesterol levels. The key is to look for the degree of elevation in the LDL cholesterol, whether or not there is heart disease or aortic valve disease occurring at a young age. Skin xanthomas are a clue to this disorder. And of course, a family history of high cholesterol in both parents. We've found that at least for heterozygous FH, a good portion of the genetic abnormality can be explained by a clustering of genes, multiple genes, that each have a small LDL raising effect, and we call this polygenic familial hypercholesterolemia. So it is possible to have a patient who looks like homozygous FH, but in fact, we can only identify an abnormal change in a gene from one parent and not from both parents. Okay, so unfortunately, at least in this country, we're not screening for this particular disorder as early as possible, particularly when there's a family history of high cholesterol or early heart disease in both parents. The second is that once an individual is identified, there are delays in instituting therapy. And some of that is due to the fact that we don't have enough lipid specialists, especially pediatric lipid specialists. The third is that the pediatricians are not recognizing skin xanthomas. And these can indicate the most severe form of HoFH and very early heart disease. And so it's critical that they're not misidentified as warts or molluscum or keloids. So the youngest one was diagnosed at 6 months and treatment started at 14 months. And so this was the brother of an older sibling who was already getting lipoprotein apheresis at our center, who also had homozygous FH. The mother was reluctant to test for lipids until 6 months, and she was also reluctant to begin treatment until 14 months. The recommendation is to begin at diagnosis, either both a statin and ezetimibe, or to treat them sequentially. And fortunately, we have a whole number of other choices now that, boy, when I first started, we didn't even have statins, we just had bile acid sequestrants. So it's a new day in the treatment of homozygous FH. And I say that because now, even in those who have what we call receptor null HoFH, we can really lower the LDL down to goal with multiple drugs and if necessary, a specialized procedure called lipoprotein apheresis, and therefore offer the opportunity for the first time, and this is just in the past few years, for the first time a full life to these patients. And so in addition to statin and ezetimibe, we have the PCSK9 inhibitors, and these work very well. I believe that we should go straight to the drug that's most effective and associated with the least side effects, and that's the newest, called evinacumab. Requires an infusion once a month, and very effective even in those individuals with the most severe form of HoFH. So we have so many options now. So I just step back and congratulate all those who are pushing to have these drugs available, discovered first and then available. We really ideally would want to start treatment at diagnosis. And the ideal age for diagnosis is birth. Really the youngest age that the FDA has approved for drug use for HoFH is 7, and that's for a statin. For ezetimibe and the PCSK9 inhibitor, it's age 10. And then we have evinacumab, age 5, so that's really the youngest. The LDL null means that there is minimal LDL receptor function. And our drugs, statins, ezetimibe, PCSK9 inhibitors, all rely on the ability of the liver to increase the expression and the function of the LDL receptor, and thereby lower the LDL cholesterol. Those drugs are not going to be effective in the nulls, although there is some crossover there. And so some feel that it's still worth a trial of the PCSK9 inhibitor. One of the genes that can be affected in HoFH is the PCSK9 gene. Therefore, the use of a PCSK9 inhibitor in individuals with that abnormality has been shown, at least in the heterozygotes, to lead to very effective lowering of the LDL cholesterol. So as we develop new drugs that might be specifically targeting the exact genetic mutation, then the testing of the specific mutation is going to become more important. I think the biggest obstacle is that the patients are identified, but they're not treated aggressively enough. We need to educate the physicians. There's just not enough lipid expertise to identify these patients and then to understand the newest treatment options that are out there. Well, you can certainly have both, and we're not exactly sure whether there's a higher frequency of high LPA in patients with homozygous FH, but it's certainly true for patients with heterozygous FH. And in fact, sometimes the cholesterol that's measured in the LDL cholesterol lipid panel that's coming from the cholesterol in LPA can raise the LDL high enough to make a heterozygote look like a homozygote. So we consider it a risk enhancer. We treat it like diabetes, like high blood pressure, like cigarette smoking, and therefore in certain instances it may lead the physician to try another treatment to get the LDL level lower. But remember, these are patients who are starting with very high levels and are going to need all of these treatments. And really what happens is the logistics get in the way, and that determines who's going to get what treatment, whether it's insurance denials or distance or just comfort level from the physician. Thank goodness there are always new drugs on the horizon, and it's much more difficult to test drugs in homozygous FH because of their rarity. We have an oral PCSK9 inhibitor in development. We have a study of a vaccine to create antibodies to the PCSK9 protein, so that's interesting. And we have another approach using small interfering RNA, and this could be given as an injection rather than an infusion. So that is going to be helpful. And then, you know, when I got into the lipid field almost 40 years ago, gene therapy was right around the corner. It was right around the corner. And here we are, it's right around the corner. And we're hopeful, and exciting other approach is using the new CRISPR-based editing technology to target the PCSK9 gene as well as the angiopoietin-like 3 gene. And so we're hopeful this would be a one-time treatment. So thank you for your questions, and I just want to remind you that you can call on the Family Heart Care Navigator and the website familyheart.org for any additional questions or concerns.